Hello and welcome to the Healthusiasm Podcast, a panel discussion on behaviors, innovations, and trends in health and self-care. My name is Christophe Jauquet. I'm the global keynote speaker on the future of health and self-care business, and I'm also the author of the book called Healthusiasm. Now, if you are new to the show, you might wonder what Healthusiasm is all about. Well, Healthusiasm is the aspiration that we all have to be healthy and happy. And as a result of this, every company or organization is now more than ever focused on making their customers healthier and happier. And so every month, I discuss with a panel of experts the positive changes that are shaping our health and happiness. And for this episode, we have three of your beloved experts in the panel. Calling in from Barcelona is our digital health connector, Aline Noizet.
Hola.
Our American in Paris and medical expert in digital health, Aditi Joshi.
Hi, everyone.
And last but not least, from Ghent, Belgium, human experience expert, Mo Zouina.
Hi there.
This means we are missing our, from London, customer experience and research expert, Krupa Sutar. Together, we want to amplify the healthusiasm that we see in articles, new business ventures, or even simply in the world around us. This is the third episode of the second season, and in this show, we will discuss if healthcare is a basic human right, and we'll also discuss what we can learn from community-based care in Africa. But first, some healthusiasm, some positive changes that will impact our health and happiness, and that the Healthusiasm panel wants to inspire you with. So tell me, Aline, what healthusiasm did you witness in the past month?
So I read a very interesting article coming from my beloved country, France. So a team of researchers from the University Hospital of Tours recently published an article showing the positive effects of laughing gas to treat depression. So I found it was very interesting. And they said that it could actually be the next generation of antidepressant 4 or 5 years from now. So the study was made on women, 30 women aged from 25 to 50. So they first had the MRI, and then they underwent a 1-hour session of laughing gas, and then they had another MRI. And what's really interesting is that nearly half of the women responded to the treatment by hardly showing any sign or no sign of depression weeks or even month after doing that experiment. And so what the researchers were saying is that looking at the brain, they could actually observe like a relief of a certain hyperactivation of some areas of the brain associated with depressive symptoms. So I thought it was very interesting.
That is very interesting indeed. I was laughing all the time when you were talking. Let's go to some other mental health related solutions. I saw recently that there is a growing category of mental health apps that are specifically designed for the Muslim community. Obviously, there is no shortage of mental health apps, but typically speaking, they're more oriented towards Western, psychology in general. However, there's almost, I believe, 2 billion Muslims in the world. And so the idea is that with these new mental health apps, it would be more faith-oriented as a solution. And already quite some solutions out there. I think Kalbo is one that I read a lot about. It's written as QALBOO. But there's also Ru, Saba, Sakina, and Mindful Muslim. And so what these apps do is they kind of fuse the modern clinical methodologies with the actual Islamic values, based on the Quran and the Sunnah. But beyond that, they actually connect users with professional counselors, physicians, or even with each other. And this is pretty new. I think it was really, really nice to see how actually, we started with Nike as well in the past, how suddenly they opened up their entire apparel clothing lines up to this large group of Muslims to help them actually to go out in sporting. And this is what we see now with mental health support as well. It brings people together with their professional counselors, which brings us to telehealth. And Aditi, telehealth expert, if I may say so, you had a news on that as well, some healthusiasm.
Yeah, so basically, most airlines, I don't know if anyone has ever had an emergency on an airplane, but I've been called for 3. They weren't all international flights, but 2 were national flights that I was on. And most of the time when you're actually called for it, you get a basically a packet or a backpack of things that you can use to see the patient, etc. On one of the flights, I remember this was a national flight, but it was going between New York and San Francisco. So it's a pretty long flight. And the idea was to try to figure out, do they actually need to stop the flight and get the person off the plane, right? And so they actually have a way to telephone down to call somebody to make a decision. So in that time, I was actually talking to the person, right? So I'm an emergency room doctor. This is exactly like a perfect doctor to have on a plane, really. And so when I was having that conversation with them, I could tell them, like, this is what's going on, and then they could decide what they wanted to do. Now, that uses a telephone. And so what some planes and airlines are doing in this story is that they're actually going to upgrade that a bit with the type of telehealth they're going to be using, and start actually having video encounters so that somebody on the ground, the physicians on the ground, can see the patient. The flight attendants can use tools that they have in the backpack, even if there's no doctor on the plane or nurse or any other clinician, because they're trained in it. And so then they can get more information. And so the whole idea is that by using this, they hopefully will have to ground less planes and stop delays or plane stoppage for this. And they're really just using a type of telehealth that already exists and we use for specialty consultation. So that's really interesting.
Was it mentioned which one that would be used, or?
Yeah, I think it's Delta. And so they're going to, like, which company? It's like a company that does specifically this.
Yeah, okay. Very good. And Delta is always very hot. I mean, I think they have even a chief health officer at Delta. So they're really very much focused on health and what they could bring to their customers. Other two companies I want to talk about that are very much focused on health and their customers is Google and Microsoft. First of all, Google. Google this week, they brought on a new tool, which is called AlphaMissense, if I pronounce it correctly. It's part of Google Deepmind. We talked about earlier about AlphaFold. Remember, I think AlphaFold is already in the Hall of Fame of Healthusiasm, I guess. But AlphaFold is a blockbuster algorithm, as they call it, who could predict the 200 million, I believe, protein structures out there. And so now AlphaMissense, which is a new algorithm, can sequence DNA and actually work out the different mutations that DNA might have. So it helps to identify diseases easier. So I'm not a specialist in this area, but if I read here what's in my note, what I understand from it is that each building block of a protein is based on a 3-letter DNA code. And so if you change one of these letters, that protein becomes a mutant of itself. And some mutants might work, but some mutants might actually trigger a certain disease. The problem is that even if you sequence it, there's about 70 million different possible DNA swaps that you can have in a human genome, 70 million. So it means it's kind of hard to understand what actually could be the cause of that. And so with this new tool, AlphaMissense, they will be able to more easily understand what mutations are caused to or are linked to what disease. It's not exactly there yet for diagnosis, but it will certainly be like they called it a tipline for disease-causing mutations, which was pretty amazing. I mean, we often talk about how these big companies like Google, the tech companies, shouldn't be in healthcare, but if you see what they're doing with this again, this is pretty impressive. Also impressive were the plans of Microsoft that also were shared this week. They teamed up with Paige, written as Paige. They call themselves a leading disruptor in healthcare technology, which I believe they could be, because they created the world's largest image-based artificial intelligence model. So basically what it is, it's a massive collection of over 1 billion digitized microscopic images of a variety of different cancer types. So a whole bunch of images on different cancers, and they'll be using the supercomputing infrastructure by Microsoft. And with this, they'll be building an entirely new AI model that will be the foundation for new clinical tools and markers to actually help and improve our fight against the disease cancer. So two huge companies, tech companies, making some strides with AI in healthcare. Going to another huge company, Mo. Of course, I'm not talking about you, but definitely you wanted to bring something up about a huge company.
Well, why not? I don't mind. Well, for me, innovation is more integration than novelty. When I hear a news where people say we're the first, I'm always curious because, first of all, I want to discover it. And secondly, I might want to debunk it. But today, the enthusiasm I will be sharing states that two private equity owned companies are on the verge of creating what they say is the first health platform as a service. Aditi, let me know later if that's just a title or if it's really true. It's HealthComp and Virgin Pulse. They're set to join forces in a monumental 3 billion merger. Their aim is to create an all-encompassing employer health benefits platform that promises to revolutionize healthcare for millions. HealthComp, on their side, is supported by New Mountain Capital, and Virgin Pulse is not part of the Virgin Group anymore. It's backed by Marlin Equity Partners in 2018, and they're coming together to serve a whopping 20 million members and over 1,000 self-insured employers. But that's not all. There are other people sitting at the table which ring a bell. Blackstone and JP Morgan Chase healthcare investment arm Morgan Health are also hopping on board as minority stakeholders. Now, why did I find this interesting? Because, it's happening at a time where private equity deals in healthcare are showing some interesting trends because the pandemic, as we all know, caused a surge. We've seen a dip recently, and it means that dynamics are shifting a little bit. We're getting out of that dip where private equity is willing to invest again in a more enthusiastic outlook for health investment. So a major healthcare merger that could reshape the landscape of employer-sponsored health benefits, and more especially a new dynamic in private equity trust in healthcare companies.
Interesting. And definitely worthwhile discussing maybe in another podcast as well. Healthcare as a service. I don't think they're the first one, honestly, but let's bring that up in another pod. Okay, to close out these Healthusiasms, I, as per usual, has a quick fire of unusual ones, 3 to be exact. The first, I'll go to TikTok. We talked in previous episodes about Barbie Core, which has about 1 billion views. We talked about the vagus nerves, which has about 150 million views. Go to these episodes to see what we're talking about there. But this time I want to talk about a hashtag that has 6 billion views, which is called Shower Talk. Shower Talk. Any idea what it could be? It's about showering, obviously. But there is one particular one that has 300 million views, which is right now growing enormously, which is Everything Shower. The Everything Shower. Mo, you had any idea what it could be?
No, I know TikTok is little dances and instructions, and maybe it's something, an instruction that you need to do, all the things you could do under the shower that you don't have to do outside of the shower. Maybe that's something.
No, not really. But it could be, it could be. Aline, what do you think? Well, Everything Shower, it's a weekly head to toe routine. It features hair masks, exfoliating scrubs, having oils, moisturizing balms, all those kind of things. They film it, which is kind of crazy if you think about it. But the whole thing, the Everything Shower, is supposed to take 4 hours about. 4 hours. So it's considered as some homage, if you will, to the bathing culture, using hyper stylized self-care products, accessories, what have you all, to turn the bathroom into a space of wonder, relaxation, and escapism. 300 million views. It's amazing what we see on TikToks. Second unusual one was that scientists apparently have grown an entity that closely resembles an early human embryo. What's so special about it, Aditi?
Of finding an original human embryo? Well, I mean, you could find a lot of data about their DNA if you can extract it and try to figure out what they look like, what diseases they had, find out a lot more about humans lived at that time, right? Because the way that we try to figure out like anthropology and archaeology, it's really a lot of guessing about what people ate and what they did. So actually having their DNA would be fascinating.
Yeah, that's definitely true. But the thing is, here, in this case, they grown it themselves. So how did they do it? They did it without using sperm, using eggs, or even using a womb. So it's sort of an embryo model, as they call it, made by stem cells. So it's basically a textbook example of a real 14-day-old embryo, and it even reacts to a pregnancy test. So it reacts positively to pregnancy, which is pretty amazing. And the idea behind it is that apparently in the first 2 weeks of actually pregnancy, this is a moment where a lot of change is happening. And so what they try to do with this type of embryo model is try to understand major sources for miscarriage, birth defects, etc. So pretty interesting. I mean, to me, not being a scientific person, that was pretty remarkable. An embryo made without using sperm, eggs, or womb, just made from stem cells. And then the third one, maybe? Aditi, you're not impressed, right?
It is impressive they were able to do it. But we've gotten a lot better at figuring out what stem cells and what we can do with it. So in that way, it makes sense that they were able to. But I'm not saying it wasn't a feat. That is a lot of work.
Yeah, true.
Very interesting that they could.
Yeah. I just like the title of the article as well. Without using sperm, eggs, or womb. If you're not in the scientific field, it's like, whoa. Aline, what do you think?
Was it actually related to what we discussed a few episodes ago about making that embryo or that future person ideal?
It wasn't the purpose for human enhancement. It was really to understand sources of miscarriage, actually. So, but you can imagine that that it will also be used for some human enhancement in the future, for sure. Last one, Mo, you'll love this. What are exercise mimetics?
Exercise mimetics is things that will replicate it without doing it.
Yeah, exactly. The magic solution, the magic pill you're always talking about. People are lazy. They only want the magic solution. And we talked about it in previous episodes with Ozempic, reducing appetite, making you lose weight and all of that. Well, apparently, in the Journal of Pharmacology and Experimental Therapeutics, there's a new compound that led obese mice, so we're still talking about mice tests, that led obese mice to lose weight by convincing their bodies and the muscles in their bodies that they are exercising. So it's really they mimeticking an exercise, and it apparently boosts metabolism. It increases endurance, so which is pretty impressive if you ask me. So we're talking about how big Ozempic is, and so imagine now if this turns into a drug candidate, a pill, maybe even preferably over an injection, maybe as Ozempic right now is. And you just don't have to work out anymore. You just don't have to do any exercise anymore. We're getting to that phase, Mo, where you say people are lazy and they just need the miracle pill. Well, they're working on it.
I don't know if that could ever work. Not for exercise.
It's the fitness service as a pill, the FSAP. I don't know. Aditi, you were cautious about that. You don't think it will work.
It depends on what they're trying to do exactly, right? Are they just trying to build muscle? They're trying to get mental health to be better? Are they trying to improve lung capacity, better sleep? What is it that they're trying to actually get through the exercise? Because there's a lot of benefits to exercise that can't really be built with a pill.
True.
And so it's what is it mimicking? It's probably not doing everything.
No, it's about boosting metabolism, endurance. That's what I read. And they actually lose weight because of that as well. And I found it, obviously the article was very clickbaity, if you want. But having talked about Ozempic, which is also some sort of miracle jab, I find it pretty impressive that certainly this type of things then get into the media as well. Well, thank you all for that discussion. Thank you for these Healthusiasms. Now let's move to the next segment of the Healthusiasm podcast. Is it something, nothing, or everything? So every month, one of the panelists brings an idea, an innovation, or evolution forward that sparked their Healthusiasm. The rest of the panel will then debate and share their opinion about it. Do they find it something, nothing, or everything? Mo, what sparked your Healthusiasm this month?
I might regret this topic, but I'll start it anyway because it's a very loaded topic. And when we think about the topic is about, is healthcare a human right? It's a question that is not really easy. And what I will do is I will take some angles to look at it. And I'm looking forward to all your reactions to that. So first of all, when you say right, there is right and privilege. As we know, Aline, there's two things. So the first is it institutionalized? Is it in the constitution of a lot of countries? Because there's different ways to institutionalize healthcare as a human right. It can be in the constitution, it can be in international treaties and conventions, and there's also the country's sovereignty. So there's a lot of instances that try to institutionalize healthcare as a right. Now, I don't know, and that's maybe a question. There's only 6 or 7 countries in the world where healthcare is part of the constitution. It's in South Africa. It was done in 96. It's in Brazil in 88. It's in Portugal in 76, where it's really part of the constitution. In Greece in 2001. In Spain, Aline, in 78, one of the first. But the first were Italy in 47. India also has it in the constitution, but it's more approximative. And if it's in the constitution, then the second question is, whose responsibility is it if it's in the constitution? Then it's got to be the government, right? So we're just saying it's not just a privilege for the fortunate few, but something that should be accessible to everyone, regardless of their economic status. So it means that the government is, has a role and a duty to organize and deliver healthcare to its citizens. Or if it's a right, are we only looking at the government to do it? And are we absolving ourselves of our responsibility to be healthy ourselves or to help our peers be healthy? So maybe that's a second question. Is it the role of the government to ensure that right? And if it's the role of the government, it means it's not limitless. Government involvement in healthcare can indeed seem like a knight in shining armor because it's comfortable. We lay back, we relax, and the government is organizing it for us. Well, not quite, because governments, like all instances, have limited resources, and there's only so much healthcare to go around. And when the government becomes the sole provider, tough decisions must be made about how to allocate those resources, leading to long waiting times sometimes and care rationing as we see today. And if it's not limitless, it means that, and that's my fourth point, it's not necessarily fair. The idea of healthcare as a human right emerged as society recognized the need for equitable access, but politics can often muddy the waters. Healthcare decisions can become entangled in political agendas, lobbying, and industry interests, leading to individuals being denied care based on factors that have nothing to do with their health. Some even argue that profit-driven motives of stakeholders have led to a system that sometimes prioritizes financial gain over patient well-being. So there's a dichotomy between the expectations and the trust and hope that we have as patients in government and healthcare, and the agendas that sometimes prevent instances from doing the right thing for the right reason. Fifth angle, if it's not fair, that means that it's not necessarily efficient. And as the old age debate, the way our government structures healthcare fees, we've been sticking to the service-based fee system for ages, right? Healthcare professional provides a service, it's not necessarily outcome related, and he or she is still paid for it. So it's also not efficient because while the outcome-based model rewards them based on actual health results, it's also a bit obsolete. The healthcare system existed in a time was launched in a time where healthcare was there, or the institutionalization of healthcare was there to prevent people dying from infectious diseases. So the healthcare system was there to protect from death and not necessarily from being unhealthy, which brings other challenges like lifestyle diseases and prevention that was not necessarily ingrained in the system. And we see today that only 1 or 2% of healthcare allocations are freed to foster preventative care. So the question is, if healthcare is a human right, is the healthcare system then obsolete to cater to that? The traditional healthcare system principles, they're significant, but the healthcare challenges today are more diverse, including chronic diseases, mental health issues, lifestyle diseases, and the need for preventative care. So Could we see the disappearance of traditional healthcare because it's not able to, enforce that right to everyone? Well, I think healthcare disappearing is quite unlikely. I think the concept of healthcare may evolve beyond the conventional doctor-patient model, and health management could become a daily part of life, with individuals and communities taking greater responsibility for their well-being. So there's challenges and opportunities for a more equitable, efficient, and patient-centric approach to healthcare, and ones that better adapt to the evolving needs of our society to make sure that we're still able to help people with things that matter most, which is health. Anyways, it's a very loaded topic, Aditi. So, you as a professional, is healthcare a human right?
Yeah. So this question actually, thinking about my life and one of my many lives that I've lived, I studied international health policy, and basically looking at the comparative ways that systems grow and health, like the way governments look at it. In the end, like when you're studying it, you realize that's exactly the question that you base the entire culture on, right? About the health system, is whether you decide it's a human right or it's not. So obviously, I come from a country where this is not the case. It's not considered a human right. And so because of that, we obviously have a very piecemeal system. So obviously we pay for it, we have insurance, but then because there are groups of people that need care, there have become a number of programs that popped up to try to fill those gaps. And so to your point about how, yes, this is exactly why, if you don't have it in the Constitution, you don't think of it in that way, this is the problem that exactly happens. But it also, I want to say, also trickles into other parts of culture, because it basically says that everybody is out for themselves. And so you are very individual. If you get sick, you take a lot more responsibility for it. It must have been your fault. What were the reasons? And so you don't really focus on prevention, because when you blame things on what people are doing, it's very hard to come from it and try to treat it in a way that's fair or even real. So, I mean, as a professional, you're asking, just so as a physician, none of that is actually true, right? So I think smoking is a great example. There are types of lung disease and lung cancer that are not related to smoking. Now, if you do smoke, your chances are, of course, higher to get certain types of cancer or to get COPD, surely. But you can also get it without that. Now, let's say somebody smoked for 5 years in their 20s and then they develop COPD. Is that considered a risk factor? Like, what do you do with that information? And then the way we pay for things, we take that into account as like part of the blame, let's say, whether or not it's actually related or whether or not it was caused or just was part of it. And so when I think about, like, when you talk about it as a human right and what it ends up being, you actually find that it will trickle into everything, the way that we think about jobs, the way that we think about the economy, the way that we think about poverty, the way that we think about how we treat humans in general. And so it actually, for me, is a fundamental question of like what kind of human you want to be and what kind of culture you want to develop. And I think healthcare is a really good example of what countries value based on how they answer this question.
Yeah, that's wonderful what you're saying. I think the healthcare as a system can be a catalyst for a lot of other things in interhuman relationships, because there's a factor of care. By the way, it's also interesting that the most ethical governments have citizens that have the highest trust in healthcare. So you see if the government is ethical and considered fair, the prevention and the responsibility you take for your own health is higher, because you know that they're taking responsibility. That's a very, very nice way. Spain was one of the first countries, Aline, one of the early countries to integrate healthcare in their constitution. What is your take on that?
Well, that's very interesting. I didn't know about that. So maybe my view, and to answer your question, for me, healthcare is a privilege, but because I was born and raised in France, and I think France has an exceptional healthcare system. I think we're really spoiled because we are used to having everything, access to everything. Most of it is covered for. And then when I left France and I lived in different countries, that's when you realize how good the system is and how much French people are taking for granted what they have in France. So France really cover for everybody. So the public system covers 70% of the cost. And then many people have a private insurance to cover those 30 additional percent. There's also a special fund for the people who don't have a lot of incomes, and they have access to that special fund, so they can still have access to healthcare. And then something that's also very special, and for me, growing in France, I thought that was normal. It was like that everywhere. In France, when you have a chronic disease, like let's say diabetes, or if you have cancer, then everything is covered 100% by the social security, so by the government. So when you have cancer and you need chemo, this is covered by the system. So this, and also what's going around the disease. So if you need physio for rehabilitation, that's also covered because it's linked to the initial disease. And then I remember not that long ago, sadly, I was in the US and I realized that people had to pay for chemo themselves. And I was shocked. But because I was thinking of my French mentality that for those chronic diseases, everything was covered. So I think now, even in Spain, it's a bit different because we have government system and private system on the side. But I still think like France is fantastic system, and I realized the privilege I had when I grew up to access that system, and also still today for the people who are there. But I think also access to healthcare is a choice for some people. And so when I read the article, it reminded me of a documentary I saw last week about the Amish community in the US. And there was an interesting point about healthcare. So they don't subscribe to insurance over there in the US, and they have what they call like a mutual aid funding. So they put money, all the community put money in that fund. And when someone from the community needs access to healthcare or needs an operation, they use that money to pay for the bills. And if there's not even money in that fund, they will do some community activities. They will sell some things to gather the money. So I thought it was very interesting that, and you also mentioned that community aspect. And I think also, even in France, or in Spain, having access to healthcare doesn't mean that you have access to quality healthcare, to the right healthcare. So here in Spain, for instance, the visit with a doctor, yes, we do have access, but it's 6 minutes. And that's not a lot. So I think that's also something to take into account. And something I was also reflecting on, so that's maybe more, you were talking about Spain for the private part of Spain. So we have the private insurances. And what happened here is that, for instance, if you have been diagnosed with depression in the past, and for whatever reason you want to change private insurance, well, they won't give you access to a therapist. Well, you can go to see a therapist, but you will have to pay out of pocket. They won't cover those costs. And the same for people who had cancer in the past. Like, it's more difficult for them to find a private insurance. And when we talk about private insurance, what we see as well is private insurance. There was an insurance here that was doing a test, like looking at your face. They could see your physiological age. And with that, they would actually base the insurance policy based on that. So in that case, for me, it's not universal right, but it's more right based on your lifestyle, or maybe also some genomics. And I think it's not really fair to adapt that. Maybe it's not my fault if I have a predisposition for a certain genomic condition. So that would be my take on it.
Yeah, that's a very interesting take. So as a recap, what you're saying is it's not a right, but a privilege, right? And then secondly, you were shocked that the world wasn't like France.
Exactly.
Exactly. Which is very French, of course.
Yeah.
Christophe.
Well, the world is perhaps not like France, but Belgium is. I think many of the examples that Aline put forward are also the case in Belgium, of course. Now, I've been struggling with your article and with that question, if is healthcare actually human rights? I think intrinsically I tend to say no, but actually I don't want to say no because of all the advantages that it brings, of course. I do, if you look at it from a society point of view or a company point of view, I think it kind of makes sense that you want to have your people be healthy, because healthier people, they contribute more to a society or to a company. So that's basically also one of the reasons why we try to keep people healthy, or if they're sick, we try to get them back on their feet, because they contribute more to a society or a company in general. So with that came a lot of thoughts, actually very incoherent thoughts all over the place regarding the healthcare system and private insurance companies and corporate well-being programs and so forth, which I won't go into it too much because they're too much all over the place. There's however 3 thoughts that I think I wanted to share here, and one goes back to what Aline was saying earlier as well, is that in Europe, where we have this Bismarck or Beveridge model where healthcare is reimbursed, largely 80%, 70%, depending on the countries, we don't want to pay, or we're not used to pay for healthcare. And I think that is a negative thing. I think it's good to have, this right or this privilege to healthcare, but the fact that we don't know how much it costs, the fact that we perhaps do not want to pay for it, I think is a bit of a disadvantage in our system. And somehow I would love to see that change, but I'm not quite sure how to do that. Another thought that came to mind was something that I've experienced, that I've learned when I was working with one of my clients. They actually, it was a couple, and their son had cerebral palsy, which means that the kid really couldn't move, had a lot of physical difficulties. And so he needs to do a lot of rehabilitation. And I think the mother from that couple was originally from the States. And what she realized in the rehab was that there's a lot of rehab tools and solutions that we have in Belgium that are very insufficient. If you look at what's out there in other parts of the world, China, America, what have you, she said that there's a lot of tools and devices that are a lot stronger that her son could benefit from. And so what they did is they started importing it. They set up a training center, and then they went to physicians and say, look, we have better solutions, and it's not reimbursed because we can't get it reimbursed. It's too expensive, and government would never reimburse it. But perhaps you have patients that can pay it, and maybe they're interested in coming to us. And so the reaction from the physicians was actually that they would never do that. So they would never send their patients, even if they have the means, to a center, with a rehabilitation center with better tools, better devices, better equipment, just because they think it's unfair. They think everybody should have the same access to solutions in that particular country. And so I was very shocked by it, in a sense, because the solutions are out there. There's a basic human healthcare in that country, but somehow physicians did not want to go beyond that because they're not used to it, because it's not social, because it doesn't fall under the human rights that others may have more, maybe. I don't know. So that was another thing that came to mind real quickly, which kind of shocking. And a third thing that I want to throw out there, and I thought maybe Aline has some other thoughts on that, or maybe some additional thoughts on that, is that I work a lot with digital health solution companies, even digital therapeutics. And very often what you see is that they want to be reimbursed. If I think about reimbursement, it's probably to make it more broadly available. It's put it in under the healthcare system, maybe even ask higher prices. But I always kind of regret it. First of all, I always recommend to digital health solutions really think twice before you do it, because it's a long process. Very often, it's not always that clear. It is not because you reimburse that you'll have a lot more prescriptions, or it'll be used a lot more specifically. So be very wary about that. But also regret that we want to put it into that system again, that system that is so-called social, and that because it makes sense for compounds, molecules that costs 4 billion before you can put it onto the market. The whole research 15 years long, 4 billion. Those medications are that expensive that they kind of need reimbursement. But digital health solutions are not always that expensive, definitely not 4 billion. So do you really need that reimbursement? And should you be really wanting to go into that social care system? I don't know. Those were the 3 thoughts that I had when we were talking. Is healthcare a human right? I don't know. Love to say no, but I think we need to benefit from it. I want to benefit from it. But then it comes with a lot of downsides and other reflections that I just wanted to put out here.
Yeah, I think it's a very interesting point, and that healthcare is institutionalized might bite us in the butt, because being unhealthy is cheaper than staying healthy or working, so we see it in the clinic too, in the regenerative clinic, which I'm part of, right? And then secondly, what you see is that digital therapeutics companies want to be part of the reimbursement plan, because otherwise they won't be prescribed by the physicians who do not accept something that is out of pocket. So I think they might want to be outside of it, but they know that they'll never be prescribed by physicians, right? And what you're asking them is, okay, find your own market, develop your own market, and find your patients yourself, and then they'll be able to pay for it. But they want to scale through a health expert that prescribes their digital therapeutics. And as you've stated, they won't do it if it's not reimbursed.
Potentially.
So, interesting part. I'm happy I asked the question. Aline still has a thing to say about Christophe's intervention.
Exactly, yeah. Maybe two things. So to your second point about the cost of care, absolutely agree. And I think in France, that's also a big issue. Like we have access to everything, but we don't know the value. But I've heard that recently they started included. So when you receive your monthly or quarterly report of the medical acts that you had in France, you have actually the value. How much did it really cost the system? I think that's really great, so that people can have an idea. And that was really missing. You said it very well. And then second part on digital therapeutics and reimbursement. So Germany is really the country we're looking at because they were the first one to start that. And we have 48 companies in the directory, or maybe a bit more now. But there was really like pro and cons about that. And I know of some company who actually left the directory because they said the reimbursement they were getting was not enough. And the number of physicians prescribing the DTX is not very high neither. So that reimbursement system works if you have a physician prescribing. But yeah, so there's like two issues there. And for them, actually, that one company I know that left the directory, they're now looking at the US and going directly to employers, which will give them like a bulk of clients at once.
Okay, thank you very much, team. I feel we've not said the last about that, and maybe, we all have to go to Paris, book a table at a terrace, and continue talking about in Aditi's hometown. Anyway, thank you very much for your contributions. Back to you, Christophe.
Well, before we go to Paris, there is some time that we need to take for something else. In this Healthusiasm world, we see boundaries of industries blurring between the worlds of healthcare, wellness, and consumer businesses. You can see how consumer businesses are slowly moving into the wellness and healthcare space, while the healthcare industry is paying more attention to what is happening outside of their own industry. So this brings the following question. What behavior, innovation, or trend from one industry can be worthwhile for another industry? In other words, what should we bring inside out or outside in? So, inside out, outside in, but we won't be talking about industries, we'll be talking about continents. I'll take you to Africa for this. A little while ago, it's actually almost a year ago, I wrote an article. I saw an article on Vox.com that really made me think, actually. And it probably will make you think as well. So the article started with a couple of facts. So in Ghana, there's 32 million people, and there's only 62 psychiatrists. In Zimbabwe, we have 15 million people, and there's 19 psychiatrists. Even worse, in Uganda, we have 48 million people and 47 psychiatrists, which is one psychiatrist per 1 million people. Now, if you compare that to the US, in the US, we have one psychiatrist for 7,000 people. In Belgium, specifically where I live, we have one psychiatrist for almost 6,000 people. And even in those countries, we know that is not enough. There's not enough psychiatrists out there. So that's head scratching. If you hear these numbers from, for example, Uganda, one psychiatrist for 1 million people. And so the article talked about how they are dealing with it down there. And obviously, how should you go about it? It's some very obvious questions might come to mind. You should train more people as a psychiatrist. Obviously. But it's long-term thinking. first of all, there's not enough medical schools, and it takes 12 to 13 years to become a psychiatrist. So that's quite a long number of years. It wouldn't solve the issue right now. But there's also another thing that's related to it. I mean, very often in those African countries, mental health issues aren't really considered medical, brain-based problems. And so people would rather not want to go to a physician. That's not their mentality yet. People would go to perhaps faith-based healers, where they do some type of, prayers and groups and so forth. But there's also a lot of stigma around mental health issues as well. About 83% of people would never go to talk with someone about mental health problems. This is not something that you do in their culture. So there's quite a couple of things that make it difficult to find a quick solution. And definitely training more psychiatrists might not be the immediate answer there. But there is a solution that is growing massively, and people are taking note, and that is community-based care. You should think of it as non-specialists that are providing or delivering, if you will, brief mental health interventions. These non-specialists are lightly trained, and we're not talking doctors, we're talking your grandmother, for example. And they would do so in a very informal setting, some homes, parks, whatever you can imagine. And so when I'm talking lightly trained, I'm really talking about lightly trained. I mean, we're talking some weeks of training, maybe months, but definitely not years. So how does it really look like? I mean, if you look at Zimbabwe, there is this thing called the Friendship Bench. It exists since about 2006. And it's a nonprofit in Zimbabwe that is recruiting grandmothers, or at least middle-aged women or older women who can help the communities. And they're briefly trained on depression and anxiety, how to recognize it, how to potentially treat it with specific therapies. And how it works, they sit on a bench in a park or in a yard, and people come to them and they talk about their mental health. And ever since 2006, there's about 160,000 people that were served in that way, which is a considerable number, I think. The same number was reached in Uganda and Zambia with another initiative, which is called Strong Minds, I believe. It started in 2013, so in lesser years and less years, they reached as many people. And again, nonprofit that trains lay people. And here it was not individual talks in a park. It was more group therapy sessions of about 12 weeks. So I really like that example. I mean, it's really community-based care where we help each other. And of course, I mean, I'm not saying we don't need psychiatrists. And in some cases, we really do, obviously. But I mean, it's believed that this community-based care could maybe address about 80% of the mental health issues out there. And we then need some psychiatrists for the remaining 20%, maybe even some hospitalizations if necessary. But so, why is this interesting? I mean, the World Health Organization already talks about this. They call it task shifting or task sharing, which is considered to be like a promising strategy, they call it, to address the critical lack of healthcare workers. And so the question is, in the Western world, we do favor biomedical, highly individualistic view on mental health or even health in general. But if we look around us, mental health problems are rising. There aren't enough psychiatrists or psychologists today. On top of that, we have an elderly population, and we're looking at a backlog in healthcare already. So there aren't enough physicians in general as well. So the question that I'd like to ask here to the panel is that what could we learn from this community-based care, and what could it actually mean for the Western world? Is this something that we can bring outside in or not? Aline, I'd like to hear your thoughts on this.
I think it's a very interesting topic. I'm all about community and collaboration, so it really makes sense for me. And actually, when I was reading the article, it reminded me of a company I want to share with you. So that company here, they call Estoy, and they're a company from Argentina, and they are coming to Spain now. So it's more like for the Western world that you're saying, and they're doing something similar to what you were describing. So it's like a support through WhatsApp for people who need help. So they do a lot of promotion on TikTok, and it's volunteers based. So they have an army of volunteers, and they dedicate 2-3 hours a week to be on the platform. And I was a bit puzzled by that. I'm like, but how can you scale like such a solution? No, because Western world, we're more about impact is nice, but you have to make money, you have to scale up. And talking to the founders, it was very interesting to hear them. And they said that the volunteers, they really, really like what they do, and it brings them a lot. And I really like that perspective, because now we were talking about the people that need help, that are receiving support, but the people who are giving that support and what they get in return. Maybe there are people who are alone in their house, so they don't have like much social interaction. That by helping those people online, they receive a lot in return. And I think that was very nice. And that's also something that we can learn here and see it from that perspective. And
were they trained then, the volunteers?
Yeah, exactly. So the founding team, they spend time with them and and train them on what to say. And they're actually supervising. So there was the co-founder that I met and someone else. They're always like seeing what's happening in the chats and giving them tips on what to say. And they were saying based on the cases, so there's like a triage solution when the people join the WhatsApp, and based on like say the gravity or the state of the people, they will send like a more senior person, more experienced person to chat with that person. And that article also reminded me of what you were saying in the Healthusiasm at the beginning. Those platforms that are connecting people for mental support or for other type of health based on their culture. And I think that's really raising. I've seen that a lot in Europe lately. There's that company you were talking about, the Muslim community. So company called Arab Therapy. And it's for the Arab community living in Europe mainly. And one support. So someone that would talk their language, but also share the same culture. And also for maybe the LGBTQ community, etc. So I think that's something we're seeing more and more. And maybe when it comes to technology, something interesting is also digital therapeutics. We talked about it before. And that's like the category that has the most solution when it comes to healthcare. If we look at the DIGA director in Germany, like depression and the panic attack, they're the two categories with the most solution. So there's really a need for that, and the people. So maybe that's not so much community based, but to get the support yourself. Now you don't have that stigma that we were talking about before, and people can just find solution whenever they want, 24/7, where they are using those different solutions.
Mm-hmm. And you made me think of another solution as well when you were talking. Do you know 7 Cups? 7 Cups. I mean, if you look at it up online, it's 7 Cups. It's a similar approach, and it's already pretty big. I think they have thousands of volunteers that are trained through the 7 Cups Academy, and they are actually what do they call it? Caring listeners. So you can video call with people to talk about the things you want to talk about, basically. And if necessary, the listeners, the volunteers can actually refer you to a therapist, perhaps even more quicker, because they might flag something very important. So, and I do agree, in the mental health space, there is a couple of solutions that are coming our way or already there that are doing exactly that.
And maybe something also around community that I saw and I liked a lot, when you bring the younger generation with the older generations. So younger people that can go and visit the older people in the nursing homes, or like go for a walk with them. And you really have that exchange in generational, like the younger can learn from the older, and the older, in a way, they get re-energized by those younger generations. I think community-based, that's really cool.
Yeah, I think in Belgium we have Helper with a double P. And what they do is they bring the neighborhood in contact with the ones in need. So if the elderly need to have medication and need to be taken care of, you can actually apply to help them through that application. So it's a similar kind of solution as well. Aditi, what's your thoughts? Also mentioned, I mean, there's mental health on the one hand side. We covered that quite a bit already. But there's also the backlog in healthcare. Is there some solution with community-based care there that we could think about? Or
Yeah, absolutely. So, community health workers have been the basis of global health and outreach programs for a long time. And so, and also,
True.
you know, in the article, in this article particularly, they're talking about using it in the US quite a bit. And, you know, the reality is this idea is not new. Using it for mental health is what's new. So if you think about just community health workers, you know, there's two things to say about it. One, there is a culture change happening where there is a much more team-based approach to medicine rather than the very classic hierarchical structure with the doctor at the top and other people coming down like through a list. It's changing, certainly. We're looking at things much more from a team perspective. And so making use of all clinicians at their highest level of training is actually what you want, right? You don't want, if you don't have, for example, psychiatrists to do this, and you can use community health workers to engage with their people, to understand them, to speak to them, or understand the cultural nuances per se, make them feel less like this is a stigma. All of those things are actually probably more valuable coming from them than necessarily a psychiatrist who could be used for other things, right? Maybe medications, maybe diagnosis, whatever they're doing at the top of their license. That's how we say it in medicine, working at the top of your license. And so so that culture is changing. And so the use of community health workers is probably going to grow through the pandemic. So, you know, going back to what I usually work in, which is telemedicine and even remote patient monitoring, you know, during the pandemic when people were creating these programs to use for COVID, they actually used quite a bit of community health workers in New York, right? Because there was a huge population that had a huge problem. And so to be able to roll out this program successfully, they had to use other people because all the doctors were working. They were all in the ICU. They were all in the hospital. All the nurses were working. And so they were able to use all of these other programs to be able to expand the telemedicine so people could stay at home, get information rather than having to come to the hospital. So I think makes sense to now use this for mental health. There is a shortage of psychiatrists, therapists, and part of it is because what's happened is that mental health has become much more important and recognized as important. And so people are actually getting therapy. They're actually getting help for their mental health rather than before where they may not have. It's less stigmatized. Now, in the article they talk about in Africa and many of the places they were mentioning, there's still a lot of stigma. There's still a lot of stigma around the world. There's still a lot of stigma in the US as well, but it is lessening. And now for that reason, we are going to have that shortage just because the need is growing and the recognition is higher. And so I think this is a great way to try to get more people involved because not only does it bring in your community, it helps to engage with other people, which actually goes a lot and helps your mental health a lot in general. It gets people who may feel this way and want to give back to the community in some way, they can actually do so, right? Like the use of the grandmothers, for example. I think that's wonderful, right? So the grandmothers could be grandmothers to more people. And I just think that's really wonderful. So I think this is going to be a really great way to do a lot of different things for mental health, not just a very direct care version. It's going to do a lot more.
Lovely. I fully agree. And I think the need is there, and I think it's organically will grow in that direction. Mo, what can you add to this? So many things have already been mentioned, right?
Yeah, a lot has been said. A lot of valuable input has been said. Really, really relevant. I love the intergenerational aspect. I think, as Aline said, well, I have a 26-year-old daughter who's now also coaching young people because she says, it's very hard for a younger person to confide in someone who's a bit older. So, for instance, my daughter often confides in people in the same generation, or they skip a generation. Talking to your parents or people from my age and the relationship that I have with my daughter, we have a great relationship, but sometimes they want to skip a generation or stay in their generation. So I think that's really interesting because it really makes it safe. On the other hand, on more healthcare based services, there's also services where you could pay someone to take care of you within your family. Right? Some states in the US are already reimbursing. It's not to make a living, but just to help, compensate for the time that you dedicate in helping a loved one within your family. So if you're on certain plans, you could, help them get something for your pay. And then it's kind of a reciprocal thing. It's the burden is not only on the person who decides to care for a family member, it's a bit compensated too. So both in terms of mental health, I think the intergenerational part is interesting. The cultural part is also really, really interesting. And that's what I want to warn about. I want to warn that taking a system and just trying to implement it in another country with another culture requires a kind of more holistic approach and taking into account the stigma and the culture that lives around that. But if you really want to scale it, we could expand it towards real healthcare services, right, for elderly people or anything else, and not having the caregiver sacrifice their time and resources just to take care of that. So I know that some people can really hire their own family member to take care of them. And I think that's a really sustainable model too.
Yeah. And I think you hit on something very important here. Obviously, mental health now is something which has a lot of attention, but we're living in societies, definitely in the West and also in Japan, actually, and also in China even, that are becoming older and older. And it will be very hard to procure services or help them with their health in general. So these community-based solutions will be one of the solutions that we need to look at. Obviously, there will be AI and robotics and what have you all, and maybe that's a topic for another podcast. But I think, this community, this human-based collaboration will be essential for sure.
Not just goodwill, but I think the government should invest in that. So to make it scalable, or any solution should invest in that, because I think it will be even way cheaper than organizing it in the regular system. So I think it's a win-win-win for everyone, for the government, for the person who tries to give, provide care, and for the person receiving care. And as a final one, the Harvard study of human development, I don't know if you know it, it's one of the longest studies that has been done on what makes people thrive, what keeps people healthy. They've challenged all the metrics. They looked at does food help people stay longer and be happy and be healthier? There's just one thing that keeps people healthy and living longer and a more purposeful life. That's company.
Totally.
Okay, so...
But you said that the government needs to invest in it, so that you presume that healthcare is a human right then?
No, the government is looking for money. And if they want to keep doing what they try to do and make it more accessible for everyone and make it sustainable, they could they could free a lot of budget by shifting towards community service.
So with these smart words, I'd like to wrap up the Healthusiasm podcast for this month. Thank you for listening. If you like the show, don't forget to hit the subscribe button on your favorite podcast platform. By the way, you can find us on the Shift Forward Health channel. It's a podcast channel of thought leaders who are actively designing and building the health and self-care business of tomorrow. For now, I'd like to thank our own thought leaders for their insights and Healthusiasm. Thank you Aditi Joshi, Aline Noizet, and Mo Zouina. My name is Christophe Jauquet. We are the Healthusiasm Panel, and we'd love to see you again next month for some more Healthusiasm. Ciao.